I'm Dale Needham. I'm an ICU physician and medical director of the Johns Hopkins Critical Care Physical Medicine Rehabilitation Program. And I'm going to give a very fun talk with an update on some of the latest information for post-intensive care syndrome. I'm going to specifically focus a little bit on cognition, fatigue, pain, and employment. So a little bit of background, what is this post-intensive care syndrome? I was very fortunate to be part of an international multidisciplinary panel from the Society of Critical Care Medicine that talked about and created the concept of post-intensive care syndrome, as you see in this slide on the screen. And post-intensive care syndrome, as we defined it, is new or worsening impairment in physical, cognitive, or mental health that arises after the ICU and persists beyond the acute care hospitalization. Importantly, this isn't a diagnosis. This was something that we created to help raise awareness and education because so many of our ICU survivors were going home and their primary care teams weren't aware that these problems were related to their ICU stay. So it was important for patients, their family members, and for clinicians to recognize that there are important impairments that frequently happen and are long-lasting in ICU survivors. What we really wanted to do is help prompt screening for specific impairments. We don't say that you can screen for the entity of post-intensive care syndrome, but you certainly can screen for muscle weakness, for cognitive impairments, and we wanted to prompt investigation into these kind of specific morbidities. And you know, the article that you see at the bottom of the slide is a very nice article where we talked about the WHO's ICF classification and talked about physical impairments that are associated with post-intensive care syndrome. So the focus itself is on physical impairment. So what we're going to do is start with a recent publication. So here we go, a really great paper from the Netherlands, a 4-hospital prospective cohort study that occurred over a 3 or 4 year period. They are record setting in the very large number of patients that were recruited to this study, almost 2,500 patients. 60% of these patients were elective surgery, about a quarter were medical ICU. And for the elective surgery patients, of course, the length of stay in the ICU was short at 1 day. And for the other patients, it ranged typically between 1 and 6 days. And what they were doing here is for these patients who went to the ICU, they were looking at patients' outcomes. They used a 30-item list of potential physical problems, as well as instruments looking at frailty, fatigue, anxiety, depression, PTSD symptoms, a survey of cognition, and the SF-36 quality of life instrument. And what makes this study unique is that they attempted to look at people's baseline status, so that we understood what were the impairments happening after the ICU that might have been new because of the critical illness. So they did, prior to surgery, they were able to do baseline surveys, and then patients that had urgent admissions, it had to be done retrospectively. And what they found, as you can see here in red, is the proportion of patients with new physical, mental, and/or cognitive problems in medical patients, urgent surgical patients, or elective surgical patients. So you can even see among elective surgical patients, there's a 43% incidence of new impairments. And importantly, mental health impairments commonly co-occurred with physical impairments. And here you see new problems. So again, that's what makes this study unique. You can see, for example, that particularly fatigue, anxiety, and depression symptoms were common and new problems at 1 year follow-up. So both new and long-lasting. So that was a really important contribution of a paper that happened just over the past prior months. Of course, there are limitations. There was loss to follow-up. Only 53% of the sample had surveys both at baseline and at follow-up, and they looked at most of the outcomes as binary phenomenon. They didn't try to measure the severity of anxiety symptoms. For instance, they looked at it as simply symptoms above a threshold score using the hospital anxiety and depression or the HAD scale. And the physical outcome measure wasn't a validated measurement instrument. It was a list of 30 items. So that's an interesting new paper that I want everybody to be aware of because it uniquely helps us understand about new impairments. And that paper really wants me to go back a couple more years to really think about how these kind of physical, cognitive, and mental health symptoms may hang together. And what we see here in doing a subtype analysis is what we see is across physical, cognitive, mental health outcomes that they tended to hang together. Specifically, we found these outcome subtypes. We found 4 different subtypes using these advanced statistical techniques and found that across all of these ARDS survivors, about 20% of them had mild impairment in both physical and mental health. So this paper was really important in showing us that physical and mental health are commonly co-occurring, and the severity of impairment in physical and mental health maps very well together. You can see that 3 of these 4 outcome subtypes had mild physical and mild mental health, or moderate physical and moderate mental health. That represented 39%. And then severe physical and severe mental health occurred in 24%. There was only one of the 4 outcome subtypes where it wasn't exactly mapping. You saw that 15% of people had severe physical and moderate mental health. So the really important message here is that physical and mental health impairments co-occur. And that's what the same paper from the Netherlands showed as well. So both in the Netherlands and in this national study in the United States, we showed these same things, reminding us that the head bone is connected to the body bone and why we need a multidisciplinary team. Interestingly, we also found that various ICU variables and severity of illness were not associated with patient subtypes. We also found that cognitive function, as measured in 2 different ways, wasn't associated with subtypes either. So patients' cognitive impairment may not be so tightly linked to physical or psychological things like anxiety, depression, and PTSD. And we also found that no matter which of these 4 subtypes patients fell into, each of the subtypes had a decrement from their estimated baseline status. So sometimes people say the phenomenon that we're seeing after the ICU is all pre-existing. Well, we certainly know from the first study from the Netherlands that I presented that that's not the case. And we also know from this paper as well that each of these subtypes were a decrease from their baseline state. So for example, those with mildly impaired physical and mental health had little or no impairment prior to the ICU based on retrospective estimation of baseline status. And now I want to present another paper. I really like this one because it's a systematic review of the topic of post-intensive care syndrome. And you can see that 2/3 of all of the publications happened in the last 5 years of this 10-year search period. But because post-intensive care syndrome is not specifically indexed in our literature databases, they needed to screen 119,000 articles to come up with 89 that focus specifically in aspects of post-intensive care syndrome. We had very good representation from each of the United States and Europe, where most of the studies come from. Fortunately, 80% of the studies were ranked at least good quality. Sample sizes were relatively modest, as you can see there. About 60% of the studies had sample sizes between 100 and 300, and 30% were from a single ICU, and most studies followed up patients only at a single time point. And most of these studies, in fact, 90% of them assessed only a single domain within post-intensive care syndrome. As you can see, for instance, about 40% of the studies focused on mental, 40% focused on physical. So it was really just a sliver of studies that tried to capture physical, cognitive, and mental health, as you saw in the last 2 studies that I presented. And that's because it's a big challenge to do that large and comprehensive assessment. And then most importantly here, they synthesized across these 89 studies 60 different risk factors. And we found that about half of the risk factors were patient-related, half of them were ICU-related, and most of them were not modifiable. But we shouldn't distress there. These non-modifiable risk factors really tell us which patients we should be focusing on most. We need to think about our older patients and those with higher severity of illness as having greater risk for physical impairments. We also need to recognize that mental health impairments seem to happen more often or be reported more often in women, in people with pre-existing mental health problems, and patients that report having a negative ICU experience. And then finally, not surprisingly, one of the most important risk factors for cognitive impairment was delirium in the ICU. And many people have said, okay, are there some common mechanisms that lead to these impairments? We know that most ICU patients have a hyperinflammatory state. And does that cause, for example, breakdown of the blood-brain barrier to cause some neurologic issues? And I want to highlight a very new study here. This was a study that we just very recently published that answered this exact question. So there's some pre-existing hyperinflammatory subtypes among patients with ARDS. So some of our colleagues have specifically already done a lot of work to say, hey, some patients with ARDS seem to have higher inflammatory markers than other patients. And we wanted to say, are those patients with higher inflammatory markers that we know have worse short-term outcomes? Do those patients with higher inflammatory markers also have worse longer-term outcomes? So here we were fortunate to use a multi-center randomized trial, the SAILS trial, as a way to evaluate that with these two existing inflammatory subphenotypes. And we had 243 patients from across the United States that had in-person functional assessments at 6 and 12-month follow-up. And in fact, we found, not surprisingly, those patients with a hyperinflammatory state were less likely to survive at 1-year follow-up. But we found that worse survival really didn't differ beyond 90 days. So really the association of hyperinflammation with worse survival really plateaued beyond the 90-day stage. And first time ever, we demonstrated that these physical, cognitive, and mental health outcomes were similar whether patients were hyper versus hypoinflammatory in the ICU. So we suppressed some of that excitement or that hypothesis that inflammation in the ICU may lead to these long-term physical, cognitive, and mental health outcomes. Of course, there are many limitations with this study. We can't do performance-based measures of patients' physical, cognitive, and mental health status before they become critically ill, because that's an unpredictable state. There are also the potential survivor bias, and certainly this is one study and more validation is needed. But one of the important take-home messages is that these inflammatory subphenotypes largely reflect acute illness and patients' short-term impacts, things like short-term mortality and mechanical ventilation duration. But I want to focus and talk about non-pharmacologic interventions then. So here again is a recent systematic review that wanted to capture the effectiveness of non-pharmacologic interventions for outcomes after discharge. This is a pretty important topic that helps synthesize what we know. And they found a total of 36 studies. 95% of these were randomized trials, but unfortunately, these kind of post-discharge follow-up studies can be quite challenging, and they had incomplete data or lost to follow-up in about half of the studies. But let's dig in and see what kind of interventions were being looked at. So we saw here 44% of the interventions occurred in the ICU, 31%, for example, happened after hospital discharge. And more than half of the interventions that had been evaluated to date are focused on physical rehabilitation or exercise. If we go to the right side of this slide, we can see that there's an awful lot of heterogeneity in how we're measuring patient outcomes. In fact, 73 different instruments were used, and 49 of these instruments were used in only a single one of these 36 studies. We can see that 80% of the studies evaluated patients at 3 months, and it was lower beyond that. And the outcomes that were most commonly evaluated are shown here. So quality of life was evaluated in almost 50% of the studies, and then you can see less for mental, physical, and cognitive health. So this is a nice paper just to give us sort of a lay of the land of what the research has been done. We see that non-pharmacologic interventions to improve long-term outcomes is really a pretty new phenomenon, with only 34 randomized trials done for any type of outcome, physical, cognitive, or mental health. And we really do, to move the field forward, need to use best practices to engage patients and reduce loss to follow-up, and to standardize the measurement instruments that we use in these studies. So I'm going to build a little bit more on cognition. I'm going to focus a little bit on this aspect of post-intensive care syndrome. We know from these prior studies that impairments in cognition are new and long-lasting. These studies that I cite here are not new studies, but it's just a reminder of some of the landmark studies telling us that patients that are in the ICU, patients that are hospitalized but not in the ICU, both of those are incrementally worse off in terms of cognition than those that were never hospitalized. And we see that in older survivors of severe sepsis, that there's a fourfold increase in new moderate or severe cognitive impairment. Just a couple of the foundational studies. And here's another foundational study that reminds us that the duration of delirium is strongly associated with long-term cognitive impairments. With 1 year follow-up of these respiratory failure patients or shock patients, 1 year follow-up, a third of them having cognitive test scores consistent with moderate traumatic brain injury without them ever having had moderate traumatic brain injury. It's just their cognitive scores made it appear like they had TBI. So what are some of the new data? So here we go, very hot off the presses, is a very interesting study that again builds on this issue. Is inflammation and coagulation markers in the ICU, are these in ICU biomarkers associated with 3 and 12-month outcomes, both in cognition and instrumental and basic activities of daily living? That was the question asked in this very recent publication. And the main results here is that none of these biomarkers that they looked at were associated with long-term cognitive function. They found that 2 of the biomarkers, including CRP that we commonly use to measure inflammation, was associated with greater disability in activities of daily living, but none of the other biomarkers were consistently associated with disability outcomes. So it really helps us build on the prior paper of that phenotypes that I talked about. It shows a consistent signal that inflammation in the ICU is not associated with patients' longer-term outcomes, particularly cognitive outcomes. But it really raises the question about, is it patients with prolonged inflammation? Because we do know that some patients aren't able to control that inflammation, have prolonged increased inflammatory markers after the ICU. Might that be part of the mechanism behind physical or cognitive impairments? That's really a role for future research. And that's, I'm going back to the study that I talked about previously, emphasizing that the study I've just presented in this paper really show these same signals, that inflammation in the ICU really reflects acute illness and short-term impact. So we're fortunate to have 2 papers with different populations asking similar questions, published relatively recently together, that help us solidify that understanding. So that led a group of us to publish this very recent editorial. I'm not going to go through all of this, but I really wanted you to see this figure that we put together. It was our best attempt, with input from many people, about how these things fit together. How does post-ICU cognitive impairment and physical impairment fit together? And what are the risk factors, and how is this associated with other things like depression, anxiety, sleep? So I show this really to refer you to this if you're really thinking about these kind of issues, in order to try to understand and move the field forward in terms of post-intensive care syndrome. So that's a free full text article. And what about fatigue? I think, especially with the COVID-19 pandemic, I think the world has recognized that fatigue can be a very common issue. And that really led us to specifically do a paper that looked at fatigue in the first year after ARDS. Again, a very, very recent paper where we were fortunate to study 732 patients from 38 hospitals across the United States. These patients were all in randomized trials where we did follow-up at 6 and 12-month follow-up. And we looked at lots of different things. We looked at fatigue along with physical, cognitive, and mental health measures to find out what fatigue was like and how it hung together. And we were very fortunate with a lot of hard work. We had at least a 94% response rate. So we didn't have a lot of problem with loss to follow-up and the biases that are introduced. And we found that at 6 and 12 months, at least 2/3 of people reported clinically important fatigue without a lot of improvement over time. We saw that, in fact, between 6 and 12 months, 28% of people worsened, 31% reported no change, and 41% said that things improved. And we saw that increased fatigue was reported more often by women and by people that were unemployed before their ICU stay. And we also saw that at 6 months and 12 months, that patients with decreased physical functioning and increased psychological symptoms also had worsening fatigue. But there was no association with severity of illness in the ICU or with ARDS. And that's a really important thing. For those people like me that focus in the ICU, we often think that how sick people are must predict what their long-term outcomes are. But we've seen in terms of mental health outcomes, sicker patients with a greater severity of illness aren't necessarily more prone to mental health problems. It's really the entire spectrum of critically ill patients. And it was the same in terms of fatigue. You know, if patients had ARDS, it didn't matter whether they were more or less severe with the ARDS, that wasn't associated with their fatigue symptoms. And what we showed here in these Venn diagrams is the overlap. If a patient is talking about having fatigue symptoms, we showed that 46% of people also had physical impairments, and more than a quarter of patients had fatigue along with anxiety and depressive symptoms, had all three of those simultaneously. So fatigue really should tell us that we need to think both about physical and mental health issues because these may be commonly co-occurring. And what about longer-term bodily pain symptoms? So again, using that same study, that ARDS study, we looked at patients' self-reported bodily pain at 6 and 12-month follow-up. And here we see again that high amounts of bodily pain do seem to be commonly reported in more than 40% of patients at 6 months and at 12 months. And we see that between 6 and 12 months, 20% of people had an increase in pain and 52% had no important increase. And once again, kind of similar to what we saw with fatigue, is that patients with pain commonly also reported physical impairments. 33% of people at 6 months, 15% at 12 months, and people commonly reported pain plus depression and anxiety, more than a fifth of people at each of 6 and 12 months. And if we just look at people that present to us with pain, if they're coming to see you as an outpatient, they say, I'm having long-term pain after the ICU, we see here a very high proportion, 78% of people with pain also report having anxiety and or depressive symptoms or having cognitive and or physical functioning. So once again, the head bone is connected to the body bone. That's why the concept of post-intensive care syndrome was created, to recognize that these things can and do commonly co-occur and can be long-lasting. And how might all of this affect people's return to work? And we're very fortunate to have some expertise to talk about this during the panel discussion. So what we see here is a systematic review where we tried to synthesize all of the studies on return to work. And in fact, there's a fairly large literature here, 52 studies among previously employed ICU survivors with more than 10,000 patients studied. We see that about a third of previously employed ICU survivors are returning to work at 1 to 3 months. About a third are returning to work, meaning about 2/3 are not returning to work. And between 6 months and 5 years, the signal is relatively the same. Only about a third are returning to work between 6 months and 5 years. And some of those longer term follow-up studies really are not seeing improvements in return to work as we go beyond 1 year. So that inability to return to work sadly may become a permanent phenomenon when we're beyond the 6 or 12-month follow-up follow-up. And those return to work statistics didn't vary by whether patients had ARDS or not, did not vary, interestingly, if they're in the United States, Europe, Australia, or New Zealand. And even if we celebrate return to work, we need to recognize some of the more detailed studies told us that yes, people return to work, but perhaps a fifth to a third lost their job after initially returning to work. Up to 2/3 may have actually had to change their occupation. And many people had worsening employment status, meaning they had to take a lower paying job or work fewer hours. And we see that most patients accrue substantial lost earnings, could be up to $180,000 in lost earnings over a 5-year follow-up period. So in conclusion, ICU survivors commonly experience delayed return to work. Those who do return to work may have worse outcomes, and we do need to be thinking about interventions. And that really helped spur a series of papers that I'm presenting on behalf of Dr. Han Su, who's in our panel, that really helped us better understand this. So again, using our national study of ARDS survivors, we were able to extract the patients that were previously employed, showing that almost half of them remain unemployed at 6 and 12-month follow-up. And when we were looking at risk factors for this unemployment using multivariable regression, we saw that patients with high physical impairment and low psychosocial impairment were very unlikely to return to work compared to those with no impairment. And those that had both high co-occurring physical impairments and high psychosocial impairments, the odds ratio there is 0.07. So roughly 93%, a 93% lower odds of returning to work, a 93% lower odds of returning to work if patients had co-occurring physical and psychosocial impairments that were high. We also saw a very strong association of fatigue symptoms and pain symptoms with not returning to work. Interestingly, we saw that people's pre-ARDS job characteristics were not associated with return to work, which we find kind of unusual and spurred Dr. Su and us to do a separate paper that I'll talk about. So these kind of physical and psychosocial impairments, pain and fatigue, are important predictors of job loss. And we really do need to be thinking about rehabilitation interventions, improving patients' impairments in order to improve their return to work. So Dr. Su and colleagues thought, okay, it didn't maybe make sense that people's pre-ARDS job wasn't associated with return to work. And she wanted to dig in a little bit further and said, okay, let's think about the imbalance. What capacity was needed for their job? And is there an imbalance between what is needed and what patients' actual abilities are? So that was the question here. And we demonstrated that 6 and 12 months, virtually everybody, 90% of people, had important imbalances between what was required by their job and what their actual functional ability was at 6 and 12 months. We found that patients with both physical and psychosocial imbalances happened almost a third of times at 6 and 12 months. And we found that having imbalances in both physical and psychosocial areas were strongly associated with joblessness, as shown with those adjusted odds ratios. So about a 2/3 reduction in the odds of returning to work if there was an imbalance between what the job required and people's abilities in both physical and psychosocial areas. So we did show, in fact, that this imbalance was really important. So we do need to understand that what a job requires, what somebody's abilities are, and if we can have occupationally focused interventions that may be very helpful, as well as thinking about work accommodations. What can be done at the work level to make it more feasible for somebody to return to work? So work accommodation also is going to be tremendously important. So I'm going to begin to try to draw some of this to conclusion and synthesize things. We certainly know that ICU survivors are increasing with the aging population, the increasing rate of ICU survival. We also know that with the COVID-19 pandemic, there's an unprecedented illness of critical illness. We have never seen this amount of critical illness in our entire life. And this is going to mean that we're going to have even more ICU survivors. And the legacy of survivor and critical illness for many people is post-intensive care syndrome. We really do need to raise education and awareness. And what I've presented to you is some of the very newest updates in the literature, helping us understand co-occurrence of impairments and understand about fatigue, pain, and unemployment. So you may say, okay, Dr. Needham, that was, about 30 minutes. I want some more information. So here's a chance for more information. If you go to our website, Outcomes After Critical Illness and Surgery, we also, of course, are going to have a multidisciplinary panel for question and answer. You're going to see here, if you want to get a monthly update on the latest literature in this field, I would invite you to email my assistant, Kim Madison, at the email address here. We've got an email list of more than 3,000 people from around the world who get updates every month on the latest research and education. And then for people that really want to dig in and understand these long-term outcomes, but also understand what can we be doing in the ICU and across the hospital to improve these long-term outcomes, I invite you to our 3-day 10th annual Johns Hopkins Critical Care Rehabilitation Conference. Because of the pandemic, this is a virtual event. We deliver it in 2 different formats. Each format is identical. With registration fee, you can attend one or both. It's identical content, on-demand access to all of the recorded presentations for an 8-week period from October 21st to December 15th. That's unlimited viewing anywhere around the world, any time zone at your leisure. And then the same content is presented live, along with live workshops and live question and answer and panel discussions on November 4, 5, and 6. So I invite you to come to the Johns Hopkins Critical Care Conference. And what I'd like to do before we move to the question and answers, of course, this is just a small sliver of our multidisciplinary team that makes this kind of research and makes our conferences and our webinars possible. So I really do want to thank them. So with that, I don't want to slow things down any further. I do want to move us on to our multidisciplinary panel. So we'll end the polling now, and then we'll move on. And both myself and the panel members will unmute and turn on our video cameras and be very happy in order to get questions. So I want to give a little bit of information to people who are not familiar with the Zoom webinar format. So if you have questions, if you look at the bottom of your screen, you'll see the Q&A box. So just click the Q&A box, type your question in there. If you want to ask a question verbally, and if you've got a microphone, you can try raising your hand, again using that icon, and we will unmute you. You may also have to unmute yourself as well, so that you're able to speak if you want to ask a question or respond to a question. And then in case we get a large number of questions and we're not able to answer all of them, I do want you to know that you do have a chance to like a question using that thumbs up icon, and that will give a question higher priority for the panel to respond to. And you can also comment on questions. You can add your own thoughts to questions using that comment icon as well. So with that, I'm going to begin to open the questions and welcome everybody to please type in your questions. We're very happy to speak with you and let's get things going. So I'm going to start with a question from, I think, Bryn. Hopefully I pronounced the first name correctly. So Bryn asks us, why is the MMSE utilized versus other assessments such as the short blessed test? And I'm going to answer a little bit about that, and then I'll ask Dr. Megan Hosey, and I'll also ask Jackie Seifer if she's interested in responding. So I think I should spend a minute and tell you who's on the panel so you know the expertise. So I've alluded to Dr. Megan Hosey. So Megan's a rehab psychologist who works exclusively in the ICU, and her expertise is specifically in critically ill patients and survivors. Jackie Seifer, who I've alluded to, is an acute care occupational therapist who again has specific expertise in the ICU setting. And then Han Su, Dr. Han Su is an ICU nurse who's finished her PhD, and you saw me specifically highlight some of the work from Han, whose expertise is around return to work. So you've got a nice collection of panel members to help. So I'll start with Bryn, and then if Megan or Jackie unmute, then I'll know that you want to also help with Bryn's question. So Bryn's asking around MMSE. So Bryn, what you saw us present were research studies where we have to be careful of what outcome measurement instrument is used, what's feasible, what's accessible. But what we didn't go into in great detail is some of these outcome studies could only use a screening measure like the MoCA or the mini mental status, but I didn't go into the details. Some of these studies also used a very detailed battery that took around 30, 40 minutes that looked at many aspects of cognition in detail, like executive function and short-term memory. So it really is a variety of instruments that have been used in the research, even though I may not have been able to highlight on them. And that is a pretty tricky area. Maybe I'll have Dr. Hosey comment if she has other things around cognition measurement. Over.
Just echoing what Dr. Needham said. So the cognitive assessments we do in research are of course going to be different than those we do in clinical practice. I'd invite folks to check out the Improve LTO website that highlights all of the measures that we recommend and have been Delphi approved to use in research. So that is from the research perspective. Where for clinically, we really want to think about things like the BLESSED, the MMSE, and the MoCA as brief screeners that give us a red flag when patients screen positive. And that suggests that patients need more in-depth testing with a trained and qualified specialist, like a trained neuropsychologist or speech language pathologist or occupational therapist who do in-depth cognitive testing, paired with interventions to help patients with cognitive rehabilitation after they have their deficits kind of fleshed out. So I know that that doesn't get into a specific distinguishing between MMSE and the BLESSED, but I would just say, again, those are both screeners. They're great for identifying a red flag, but not comprehensive enough for clinical care.
Jackie, is there anything you want to comment on?
You guys did a great job. That's what I would say also, like using those short kind of screeners in the ICU setting to help you identify problems and then diving in deeper and using our treatments to kind of address the problems that we identified. So, yeah. Great.
And for Dottie, I'll give a quick answer. Dottie's asking about starting a PICS clinic and going through the budget process. And Dottie's saying, if we were limited in our team members, which would we consider? Well, Dottie, that's a good way to get me kicked off the stage, huh? I'm just teasing, Dottie. I think what I would like to direct you to is we have an entire 1-hour webinar on COVID follow-up, which will touch on this, which will focus on this in a great deal of detail. So I'm intentionally not going to attempt to answer your question because I think it's going to be, we specifically have a panel together that does long-term follow-up after critical illness from COVID. And I think it's very similar kinds of resources that would be used in that follow-up clinic compared to others. So I'm going to leave that to Dr. Ann Parker, who's the director of the Johns Hopkins PACT clinic that does follow-up, and she will have a multidisciplinary panel. So I'm sorry that you'll have to wait a little bit to hear back. I do want to address a question from Peter Neidl. So Peter's an ICU nurse who I know well for Germany. He also importantly highlighted that social impairments is part of post-intensive care syndrome. And in fact, again, at that same website, www.improvelto.com, Improve LTO is all one word, you will see a fair bit of information around research around social impairments. That's researched less often than physical, cognitive, mental health impairments, but clearly this is a really important issue around different roles, social isolation, and I'm hoping that Jackie can maybe comment on her thoughts in terms of that and what we need to understand about social impairments.
Sure. I think social isolation is something that we discount a lot in the ICU, and using kind of occupational therapists to help engage in socialization. A lot of times, if I'm doing mobility with an ICU related patient, I will have the family members, if they're there, interact with them. If they sit up on the side of the bed, are they opening their eyes? Can they interact with their family member? And then, of course, getting them, if we can, to a chair to help with that socialization process. But also for kind of our lower level patients, doing some education with the family members on kind of multi-sensory stimulation, being able to hold their hand and talk to them, and promoting some of that socialization, even for our lower level patients, I think is a very important thing. And that would be, that's my answer.
Dr. Hosey?
I think related, another literature that's important is PICS family. So we didn't get a chance to touch on that a lot here, but we do know that there are international studies identifying anxiety, depression, and PTSD symptoms in family members of ICU survivors. And we're starting to find that there are modifiable risk factors for that. So that is a very important literature and space to continue following for the social support of our patients as well.
And importantly, for people that want the very latest literature, just yesterday, an amazing combination of an ICU doctor, Lauren Ferrante is the senior investigator, and a physical therapist published a paper in, I think it was JAMA Internal Medicine, specifically looking at social isolation and patients' disabilities an entire year later. And that was a pre-pandemic paper, but they brought it up because the pandemic has worsened social isolation. So that's some new literature in the field. I'm going to direct Megan or Jackie to respond to a question in the chat from Leonard, from Amanda, that's asking to spell out some of the cognitive assessments. So if you guys scroll down, could you type an answer so that we could keep moving forward? So there's a question around when is the best time to start rehab for ICU patients? What are the things to consider? Well, Leonardo, we have an entire 3-day conference on that, and that has to be one of the most commonly asked questions. So if you go to the website that I talked about, OASIS, Johns Hopkins Outcomes After Critical Illness and Surgery, you'll see that there's some information there. You'll also see that there's a few great papers on screening criteria, or a red light, green light, orange light, stoplight criteria for rehabilitation. And that may help as well. Also, you may see that just in the last 2 days, Peter Neidel, one of the nurses that I talked about, as well as Carol Hodgson, a PT, PhD faculty member from Australia, myself and others, have published a paper in a journal called Critical Care. It's a free open access article on 10 strategies for promoting early mobilization in the ICU. So that's a free full text brief article to help. But a more direct answer, Leonardo, to try to give a 3-day conference in one sentence, is the moment that a patient stops getting worse is the moment we need to start thinking about rehabilitation and recovery. So if there's not a clear cutoff for a PEEP or an FiO2 or a vasopressor dose, when we have them physiologically stabilized, then we begin to start rehabilitation. So patients may have an endotracheal tube, they may be on vasopressors, they may have continuous dialysis. They're not necessarily running down the hall at that stage, but we have the highly skilled OTs, PTs, speech language pathologists, psychologists, seeing patients and beginning to start the recovery process right then, in conjunction with input from ICU doctors and ICU nurses. So the moment patients stop getting worse is the moment that we start this. So often, to give you some statistics, in my medical ICU where Dr. Hosey and Jackie and I work, often this happens within 24 to 48 hours that a PT or OT may start seeing patients to help with their recovery process. So thank you for people that are continuing to respond to the polling questions. You know, I want to ask one of the questions to Dr. Su. If Dr. Su can unmute, people are wondering how it is they should be thinking about the return to work process. Can you talk a little bit about how we might think about workplace accommodations? What kind of next steps should be, you know, designed and evaluated to help with return to work? Dr. Su, could you unmute?
Thank you. That is a great question. So I think return to work is a process. So before they actually return to work, they start to thinking about return to work. So as a healthcare provider, I think we can provide them some information as they trying to find some information to return to work. So for example, like occupational therapy or vocational therapy, they might have a lot of information can help them to figure out whether they are suitable or whether there are some resources they can utilize as they try to return to work. And then when they are actually return to work, the main important thing is that whether their ability can match with the job demand. So in this case, the workplace accommodation can have a role in here. So for example, people's ability might decrease after ICU, but their workload demand is high. So in their workplace, we might try to reduce their workload and try to balance their ability. And then in this case, they might be able to maintain in the workforce. Does that answer the question?
Great, thank you, Dr. Su. So I want to try to answer one last question, the question that has the most thumbs up at the moment. And again, people are trying to get me kicked off the stage. They're asking me to pick one specific area to focus on in the ICU to reduce the burden of post-intensive care syndrome. Melanie suggests it would be delirium, but Melanie, you won't get me to pick one answer. The head bone is connected to the body bone, and I think we are going to see the best outcomes when doctors, nurses, OTs, PTs, speech language pathologists, psychologists and other people all collaborate, because you're right, if we work on delirium, then we're hopefully going to reduce long-term cognitive impairments. And also when patients are less delirious, they're going to interact and have higher functional performance with our OTs and PTs. But we also know that our OTs and PTs in working with patients, along with our speech language pathologists, can do many things to also improve delirium. We know that physical movement can help improve delirium, even if it wasn't specifically targeted to cognition. So the head bone is connected to the body bone, and we really do need to bring the team together. And that's the whole reason that we planned the 3-day Johns Hopkins Critical Care Rehabilitation Conference. It's the way for us to bring together PTs, OT, speech language pathologists, ICU doctors, ICU nurses, respiratory therapists, psychologists, psychiatrists, outpatient clinicians, in order to think together as a team. Because if we want to optimize our patient outcomes, then we really are going to need to have all of the disciplines together, and have all of the disciplines together working as a team. So I know that Peter Neidel asked another question about how do we get our teams excited about this in the ICU, where traditionally we may be focused on bed rest and on deep sedation. And it's really important to know that before we attempt to provide education and share studies, we have to focus on engagement. And some of the best ways to focus on engagement is through the patient voice. You know, in the early days, 15 years ago, 20 years ago, we had some of our ICU survivors that doctors and nurses thought may have been a major success story. A very sick patient that survived the ICU stay, we brought them back into the ICU to enlighten us that in fact they hadn't returned to work a year later. They were still having ongoing fatigue and problems with cognition and problems with mobility and these kind of things, and really helped us recognize that we needed to start that recovery process much earlier in the ICU in order to decrease the downstream effect of post-intensive care syndrome. So with that, we've reached the top of the hour. I thank all of our panelists for sharing time with us. I thank all of our people that responded to the polls, chimed in with questions. I'm sorry that we couldn't answer all of them, but we really do appreciate you participating with us. We hope that you will register for at least one or two or all three of the remaining webinars. Share it with your friends. Also, for those that can't participate, remember that ICURehabNetwork.org has these free webinars downloaded. They'll be there in the coming days after each of the four of them. So thank you so much. We look forward to seeing you at the next webinar. Best wishes and goodbye.